Every patient deserves the right to a safe and clean surgical environment. Similarly, everyone working in the operating room suite has the right to be protected from potentially harmful pathogenic microorganisms. Contamination in the operating room can come from various sources. The patient, healthcare personnel, and inanimate objects such as equipment for measuring vital signs are all capable of introducing potentially harmful microorganisms to the surgical environment. Efforts to confine contamination, together with a well-developed sanitation program, can reduce the risk of developing a healthcare-acquired infection, otherwise known as an HAI. HAIs account for over 100,000 deaths and millions of infections annually in the United States. The content of this video is in accordance with the latest AORN recommended practices for environmental cleaning in the perioperative setting, and the evidence-based guidelines for disinfection and sterilization in healthcare facilities from the Centers for Disease Control and Prevention. Some of the content of this video may supersede the currently published AORN recommended practices for environmental cleaning. All content of the video was current as of the time of filming and publication. AORN also recognizes that there are numerous types of settings in which perioperative nurses practice, which include not only the traditional OR setting, but also ambulatory surgery centers, physicians' offices, cardiac catheterization suites, endoscopy suites, and other areas where operative or other invasive procedures may be performed. In this video and accompanying study guide, we will describe the importance of cleaning and disinfecting the OR suite, demonstrate the principle of confine and contain, discuss strategies to properly evaluate EPA-approved disinfectants registered with the U.S. Environmental Protection Agency, EPA, as a hospital-grade disinfectant, differentiate between preliminary, interim, and terminal cleaning, and list the high-touch areas within the OR that should be cleaned and disinfected. Hand contact with contaminated environmental and medical surfaces and equipment is the primary way in which microorganisms are transferred from the environment to the patient, the sterile field, and to healthcare personnel. According to the U.S. Centers for Disease Control and Prevention, hand hygiene, HH, is the most critical intervention in reducing the risk of microorganism transfer. However, a clean surgical environment is fundamental in reducing the incidence of healthcare-associated infections. Exogenous sources for pathogens that may cause a surgical site infection, SSI, include surgical personnel, the perioperative nurse, and the operating room environment. HAIs have been scientifically linked to external sources such as environmental surfaces. The conscientious application of AORN's recommended practices and guidelines should provide a clean and safe environment for all surgical patients. Before we actually get into the mechanics of cleaning and disinfection, let's review some of the pathogens that are commonly found in the perioperative environment. Infections may be caused by single organisms or combinations of these microorganisms. Methicillin-resistant Staphylococcus aureus, Escherichia coli, VRE, Streptococcus, Mycobacterium, extended-spectrum beta-lactamase, ESBL, producing organisms such as E. coli, New Delhi metallobeta-lactamase 1, NDM1 organisms, tuberculosis, Pseudomonas, Serratia marcescens, multi-drug-resistant gram-negative bacteria, Clostridium difficile, pathogenic fungi such as Candida albicans, blood-borne pathogens including HIV, hepatitis B virus, and hepatitis C virus. You may refer to the study guide for a comprehensive list of other common pathogens found in the operating room and other healthcare settings in which surgical procedures may take place. AORN's recommended practices for environmental cleaning in the surgical practice setting state that patients should be provided a safe, clean environment. In order to accomplish this goal, cleaning and disinfection should be performed on a regular basis. That is, before and after each surgical procedure and at the end of each day. Environmental cleaning and disinfection is a team effort that involves both surgical personnel and environmental services professionals. However, the ultimate responsibility for ensuring that a clean surgical environment exists for each surgical patient rests with perioperative nurses. Environmental services professionals must have knowledge of aseptic techniques and proper methods used during interim cleaning processes.
Your hands, if you're not wearing the appropriate PPE, which is personal protective equipment, everyone knows that?
Yes.
It is only through this collaboration with our partners in environmental services that the surgical team can completely assure patient safety through a clean environment.
Well, Beth, good morning.
Good morning.
First case of the day.
Starting in about an hour, don't we?
Yeah. So we got some stuff we have to get some things out of here first.
Okay.
Preliminary preparation of the OR is completed by the circulator and scrub person prior to the first case of the day. Assistance can be provided by the environmental services professional.
What if you clean the lights and I'll clean the tables?
Sounds good.
Environmental services personnel can also provide assistance with interim cleaning and are usually responsible for the terminal cleaning of the operating room. One way of ensuring that the perioperative nurse is protecting the patient from a hospital-associated infection, HAI, is the use of standard precautions. Every patient should be considered a potential contaminant in the environment and as such be treated exactly alike regardless of procedure. Thus, standard precautions should be practiced by all staff members to minimize the risk of disease transmission no matter the condition of the patient. AORN recommends that the patient be provided with a clean, safe environment. A facility-approved, EPA-registered, hospital-grade disinfectant should be used to clean floors, furniture, and equipment in the surgical suite. These items are classified as non-critical items, meaning they come in contact with intact skin and require low-level disinfection. The selection and use of low to intermediate level germicides are a matter of judgment, guided by product label instructions and regulations. Facility infection preventionists should be involved in the selection of the proper agent for use in the environment. Manufacturers' written instructions should be followed. The facility should adhere to the recommended contact time to ensure maximum effectiveness is achieved. Ideally, a disinfectant used in healthcare facilities should be broad-spectrum and effective against gram-positive and gram-negative bacteria, viruses, mycobacterium, pathogenic fungi, and other blood-borne pathogens, and have a low overall contact time. Environmental surface germicides used for low to intermediate level disinfection are regulated by the Environmental Protection Agency, EPA, and are labeled with EPA registration numbers. The product labels specify indications for use of the product and provide information on the range of microbial activity. Users should follow all instructions on the product's label to ensure full compliance with the EPA's Federal Insecticide, Fungicide, and Rodenticide Act. Users and the facility that fail to follow all label instructions could incur personal liability. For patients with Clostridium difficile, an EPA-registered hypochlorite-based disinfectant, or EPA-registered disinfectant with efficacy claims for Clostridium difficile spores, should be used to clean patient areas and all potentially contaminated environmental surfaces and patient care equipment. Personnel must wash their hands with soap and water following cleaning of patient care areas that are contaminated with Clostridium difficile. Alcohol-based hand rubs are ineffective against this organism because it is a spore. The emulsion created when using soap and water together, with the mechanical action and friction caused by rubbing the hands together, gets the spores off the hands and rinsing washes them away. When performing environmental cleaning and disinfection, all healthcare personnel should wear protective clothing and gloves. If splash or splatter is anticipated, the healthcare provider should also wear a mask and/or face shield. Any germicide that is labeled as a facility disinfectant has passed the potency test for activity against 3 representative microorganisms: Pseudomonas aeruginosa, Staphylococcus aureus, and Salmonella cholera suis.
Oh no!
Safety data sheets, SDS, provide information on the appropriate precautions when selecting and using a disinfectant.
And so this is our manual, and you can see it's quite thick. Every single chemical in the hospital has been identified.
Users should closely review product SDS sheets and utilize any personal protective equipment, PPE, stated on the product's label instructions. All personnel handling waste should wear appropriate PPE. Infectious waste should be segregated from non-infectious waste in the general waste stream. Color-coded or labeled bags should be used to facilitate separation of the various wastes. Segregation at the point of generation can reduce volume, costs, and unnecessary exposure for personnel. Facilities should follow state and federal regulatory guidelines for handling of infectious waste. There are numerous regulatory agencies concerned with regulated medical waste. For example, the Occupational Safety and Health Administration, OSHA, the Agency for Toxic Substances and Disease Registry, the Department of Transportation, and the Environmental Protection Agency, EPA. Soft, absorbent, low-lint cloths, such as microfiber, are used to wipe all surfaces within the suite and then placed in the laundry or discarded to avoid cross-contamination. Wet vacuuming or wet mopping may be used for floor care in the surgical suite. The wet vacuum system may be used dry first in order to pick up large amounts of suture remnants and other visible debris. Wet vacuuming begins with flooding the floor, half the room at a time, with an EPA-registered disinfectant solution. This solution may be dispensed from a pump sprayer or automatic spraying device attached to a central vacuuming system or simply poured from a pail. The disinfectant is left to sit for the time specified in the manufacturer's written instructions and then vacuumed. Healthcare staff should utilize appropriate PPE as stated on the product's label. A wet mop system may be used if a facility does not have a wet vacuum. To minimize cross-contamination between patient and rooms, the mop head should be dipped into the solution only once when it is clean. A 2-mop system may also be used. One mop is used to apply the solution, and a second mop is used to take up the solution. Due to the ability of bucket solutions to become contaminated during cleaning, the cleaning solution must be changed at least daily. If the contaminated solution continues to be used, microorganisms will be transferred to each subsequent surface that is cleaned. The bucket solution can be used multiple times throughout the day, as long as the solution is not contaminated. A clean mop head must be used each time the disinfectant solution is accessed. Disinfectant solution should be properly labeled and disposed of according to facility policy. No matter which method of cleaning is used, cleaning items used must be disassembled and decontaminated after each use. Mop heads and cloths should be laundered and allowed to dry before reuse. Mop handles should be wiped down or discarded. A wet vacuum should be disassembled and disinfected and allowed to dry before reassembly. It is the responsibility of the scrub person and circulator to properly prepare the procedure room before the first case and ensure that the room is thoroughly cleaned prior to subsequent cases being set up. To avoid unnecessary clutter, excess furniture, equipment, and supplies should be removed from the OR to minimize the potential for cross-contamination. Furniture should be arranged in an organized manner away from the traffic pattern to minimize disruption of the airflow. Because dust and lint are deposited on horizontal surfaces, AORN recommends that before the first case of the day, all horizontal surfaces in the OR, for example, furniture, surgical lights, tables, and medical equipment, should be damp dusted with a clean, lint-free cloth moistened with a facility-approved EPA-registered disinfectant. Begin with the vertically higher surfaces and work down to the lower levels. This will reduce the potential for contamination from airborne contaminants that travel on dust and lint. Prompt cleanup and decontamination of potentially infectious materials such as blood or other body fluids helps maintain a safe and clean surgical environment. When cleaning spills of blood or any other potentially infectious material, use gloves and any other PPE that is appropriate to the task according to the Bloodborne Pathogen Standard from the Occupational Safety and Health Administration, OSHA, and use a facility-approved EPA-registered disinfectant. Spills of potentially contaminated materials should be cleaned up as quickly as possible. Fluids and debris left on the floor may be tracked to other areas either by human or equipment. Fluids and debris left on the floor may also dry and flake, leading to cross-contamination. Movement within the room may cause these particles to become aerosolized and contaminate the field, as well as pose a hazard to personnel. Small spills should be cleaned up using a soft, absorbent, low-lint cloth and facility-approved EPA-registered disinfectant. Larger spills may require the use of a special absorbing agent. Spray bottles are not used to apply disinfectant because they can cause particles to aerosolize and potentially contaminate the field. Sprays also create occupational health and safety hazards such as respiratory irritation for the perioperative nurse and other healthcare personnel. The primary principles of cleaning procedures are to confine and contain contamination and to physically remove microorganisms as quickly as possible. Some methods used to accomplish this goal include: soiled sponges should be discarded into a plastic-lined receptacle like a kick bucket. When counting sponges, they should be placed in an impervious receptacle such as a sponge counter or clear plastic bag. Before leaving the procedure room, soiled shoe covers should be removed to prevent tracking of blood and body fluids throughout the perioperative suite and other areas of the facility such as PACU. Personnel should utilize a hand rub product or soap and water to wash their hands after removing shoe covers.
Moving turnover belt room 12, moving turnover belt room 12, please.
AORN recommends that after each surgical procedure, a safe, clean environment be reestablished. Interim cleaning of the operating room or procedure room is performed at the end of each case in order to render the environment safe for the patient following in that room. Equipment and furniture are considered contaminated through contact with patients and other potentially infectious materials, including blood. Mechanical friction should be used when cleaning, as this technique has been shown to remove more microorganisms from environmental surfaces. Cleaning must always precede disinfection, thereby ensuring that the full action of the disinfectant is achieved. Bag all soiled linen and used disposable items in the proper bags prior to removing them from the room at the end of the procedure. Soiled sponges, other bloodied waste, and items contaminated with body fluid should be discarded into appropriate impervious biohazard waste receptacles. It is important to note that only items that, when compressed, will release blood or body fluids should be placed in red bags that are labeled and handled as hazardous waste. If hazardous waste is potentially contaminated with radioactive or chemical substances, environmental staff should be instructed to contact the environmental safety officer or radiation safety officer and follow facility policy and procedure for handling this type of waste. Drapes and gowns are impervious and will not absorb fluid. Even dried sponges with blood should not be placed in red biohazard bags unless they are caked in blood. Placing all non-infectious waste in red biohazard bags is very costly and not required. OR clinicians should follow the facility-specific policies for waste disposal. Refer to the OSHA Bloodborne Pathogen Standard. Blades, needles, and other sharps should be discarded in a puncture-resistant container labeled as biohazardous, never into any other trash receptacle to ensure compliance with federal OSHA standards. Sharp safety is important for all staff. Facilities should refer to the OSHA Bloodborne Pathogen Standard for specifics on this topic. Single-use devices that are to be reprocessed are placed in the appropriate containers. These containers also must be labeled as biohazardous. Instruments should be processed according to facility policies and transported to the cleaning location in closed carts to prevent exposure to the environment and healthcare personnel. Fluids should be disposed of in containers that are impermeable to moisture, resistant to puncture, rupture, or tears under normal conditions, and sealed for transport to prevent leakage. Extreme care must be taken when handling containers with blood, body fluids, disinfectant solutions, and other hazardous waste products. If a reusable suction system is used, the suction contents must be disposed of according to local, state, and/or federal guidelines. Personnel disposing of suction contents from reusable containers should utilize the appropriate PPE when disposing of the contaminated liquid and cleaning the non-disposable equipment. Red biohazard bags are disposed of in specially marked containers. Linens and non-contaminated trash are removed from the room. If sharps containers are full, they should be sealed and discarded according to the facility's regulated waste disposal policy. All horizontal surfaces of tables and equipment, including the anesthesia machine, should be wiped down with a lint-free cloth moistened with a facility-approved EPA-registered disinfectant. Other ancillary equipment such as IV poles should be cleaned in a similar manner. Furniture and equipment that is not needed for the following case should be wiped down and removed from the room. The OR tables should be thoroughly cleaned and disinfected, including all surfaces of the mattress, pads, and screw connections of the operating bed. Special attention should be paid to specialty beds to ensure that all potential areas of contamination are fully cleaned and disinfected. Follow manufacturer's written instructions. Lights are cleaned by wiping the outside as well as the inside of the light reflectors. The arms are spot wiped as needed. All kick buckets, hampers, and similar receptacles should be inspected and disinfected. The facility should establish a policy for the frequency of these inspections. If the floor is soiled or potentially soiled, it should be mopped with a new or freshly laundered mop head. Be sure to use either new disinfectant solution for each OR suite cleaned or use a new mop head for each room and dip in the disinfectant solution only once. Mop the OR floor from the cleanest to the dirtiest areas as needed to ensure that all potential contaminants have been removed. When mopping the floor, the OR bed should be moved to check for any items that may have slid under the table, for example, sponges, sutures, and for soiled areas. After mopping is completed, staff should allow the disinfectant to dry according to the manufacturer's instructions before allowing the room to be entered. Visually spot check the walls and ceiling. The walls do not need to be cleaned after each procedure unless splashed with blood or other debris during the surgical procedure. Furniture should be placed back in position of functional use. Transport vehicles should be considered contaminated after patient contact. They should be cleaned after each use by wiping the vehicle, including any non-disposable straps and attachments. Transport vehicles should ideally be cleaned outside of the procedure room to prevent potential contamination of the OR. AORN recommends that recycling programs